Thank you again for this very kind invitation. And again, please put your questions in the chat or to Dr. Satapathy later when we are done. And we can take a little bit of break because there's a lot here to cover. So again, hepatic encephalopathy, best practice and management. Here is the outline. We're going to talk a little bit about the definition and pathophysiology, overview of the management and classification, covert or minimal hepatic encephalopathy, then the two important situations, which is inpatient therapy and prevention of recurrence, and then special situations. We are going to briefly talk about this and future management strategies, both for diagnosis as well as treatment, what is actually being looked at this stage in patients with hepatic encephalopathy. So here is the definition. It was initially proposed in 2014, and then a CPG from EASL that came out last year also actually agreed with this. This is hepatic encephalopathy is brain dysfunction caused by liver insufficiency and or portosystemic shunting. It manifests as a wide spectrum of neurological or psychiatric abnormalities, which ranges from subclinical alterations to coma. Few things. You do not have to have cirrhosis to have hepatic encephalopathy. If you have a congenital or any other way that you have a portosystemic shunt, that may be enough. Yes, your prognosis is worse if you have liver insufficiency, but that on its own is not necessary to cause hepatic encephalopathy. The more important point here is that neurological and psychiatric abnormalities that can be subclinical are also something that hepatic encephalopathy can present as, and therefore the covert and minimal stage are so important for us to look at. So why should we care? It is now the first decompensating event amongst patients with NAFLD cirrhosis. It is independently associated with high mortality. We know for a long time that it has been associated with high morbidity and impaired daily function, and also a loss is not prioritized for liver transplantation. It increases caregiver burden and is the #1 cause for preventable readmissions. From a scientific standpoint, what really intrigued me is comatose people with HE wake up after bowel movement. And it is the best human model for the gut-brain axis. The question is now how and why. And that is why scientifically, financially, medically, and psychosocially, this is one of the most important complications of liver disease that we will ever see. The pathophysiology of hepatic encephalopathy, the name HE kind of captures the full story because it's not just the liver or the brain. It is the entire body that is conspiring to make people sick. You have the gut that is not doing its job because the liver is not doing its job. There is gut barrier impairment, there's dysbiosis, bacterial translocation. All these things like ammonia, indole, endotoxin, etc., either go directly to the liver or are shunted because of the portosystemic shunt and directly lead the systemic circulation into the brain. Once they reach the liver is inflamed. The bacterial products make it even more inflamed, starting this vicious positive feedback. There is, of course, impairment of the urea cycle, which leads to hyperammonemia. In addition, the quantity and quality of skeletal muscle is not optimal. So the other organ that can detoxify ammonia is also not working to its fullest. And the kidneys, especially in patients with renal bleeding, become net ammonia producers. Ultimately, this affects the brain, both all the astrocytes, microglia, and neuronal dysfunction. The astrocytes are what actually support the neurons. Microglia have many functions, but the more important one is they actually act as macrophages of the CNS. Ultimately, this affects the neurons. And until and unless the neurons are affected, the patient's syndrome, either covert or minimal or overt encephalopathy, does not actually appear. So you can see all these organs have to fail together or at once or in series for this to actually appear. So few animal studies, we want to find out whether gut microbiota are necessary, because if you've treated patients with hepatic encephalopathy, you can see 95% of the treatments are directed to the gut. So why is this? Do we need the microbiota to actually do this? So in our study that we published in 2016, we made mice develop cirrhosis in the conventional condition, which is con-cir here. Then the right two sides of every little panel has the germ-free mice, the same control versus cirrhosis. And you can see the inflammation as well as IBA, which is a marker of microglial function, and GFAP, which is a marker of function of the astrocytes. You can see they are really higher only in conventional cirrhosis, but not in germ-free cirrhosis in the cerebellum and the cortex. which really tells you that just having cirrhosis is not enough if you do not have microbes with it. What was even more interesting is the germ-free cirrhosis mice had a high ammonia level. Why was that? Because glutamine in the diet is broken down by the glutaminase enzyme of the small bowel. It does not need the microbes to produce ammonia. But despite this high ammonia in the germ-free cirrhosis mouse, you did not develop hepatic brain inflammation, which was the readout for hepatic encephalopathy in this group. Moreover, it just does not matter whether you have bugs or not. The brain can actually also differentiate what kind of bugs you're putting in. So again, germ-free mice, you have conventional control. On the left-hand side, conventional controls are in the blue, conventional cirrhosis are in the red, and germ-free controls, germ-free cirrhosis, mice who were healthy but were given stool from controls humans, which is in the orange, and mice who were germ-free and were healthy otherwise, were given stool from cirrhosis humans, which are in the black. And you can see IL-1B, MCP1, IBA, and GFAP are the same things, which are much higher in cirrhosis human compared to control humans, which means it's not just important for the mice to know whether the bacteria are present or not, but the type of bacteria you instill in the mouse engenders a different inflammatory reaction. So therefore, the HE pathogenesis is not only dependent on presence, but the type of microbiota in these people. And moreover, when we actually put germ-free supernatants of these human controls and cirrhosis, it had absolutely no impact, which tells you that you need live and active bacteria for this to happen. What about non-bacterial kingdoms? The microbiota just not just bacteria, it has fungi and it has viruses. And here we found in 2 studies that the streptococcus, and why streptococcus important? Not only it's important in the oral cavity that we are going to talk about, it also produces urease. Urease breaks down urea into ammonia and carbon dioxide. So therefore, it is an important target of microbial therapies. And on the left-hand side, top left, Streptococcus phages in those who did not get hospitalized with the patients with the microbiota, which are in the pink, are very dense. You can see the top part. They are so dense that you cannot even figure out who is correlated to what. In the bottom, and you can see the very sparse correlation between all microbes as well as the Streptococcus phages. On the right-hand side, the vertical panels are pre and post rifaximin therapy. In patients with minimal hepatic encephalopathy, when we gave them rifaximin, we tested the microbes correlations before and after, and this is what we found. Streptococcus satellite phage, completely their correlation with microbiota was destroyed. If you see the post one, you can see how loose they are. Same with Streptococcus phage, which tells you that these actually might be the many modes of the action of rifaximin. And in the bottom left is the fungi. As microbiota and as hepatic encephalopathy progresses, the fungal changes also happen. So all of these changes in the gut microbiota can affect the persistence and development of hepatic encephalopathy. How can these be actually relevant to clinically relevant functions in hepatic encephalopathy? When we look at the left-hand side, this is Ruminococcus faecalibacterium. For those who are not aware, this is a good bacteria. This is the bacteria that makes short-chain fatty acids, and it is negatively correlated with number connection test B, which is a test in which higher time requires shows bad cognition. So higher short-chain fatty acids means lower time to do this, which means good cognition. In the middle part is the MR spectroscopy and diffusion tensor imaging of the brain. And what we found, there are 2 groups of bacteria associated with 2 groups of things in the brain. The short-chain fatty acid producing bacteria, like the faecalibacterium we just showed, is associated with lower ammonia changes, whereas other bacteria such as pathobionts, such as E. coli, etc., are associated with higher ammonia changes in the brain. What is really interesting is the bacteria in the oral cavity are more associated with white matter changes or inflammation-related changes in hepatic encephalopathy. And what happens is both these bacteria are present in these patients. Remember the Streptococcus we just talked about, which is an oral bacteria as well, and that causes a big problem. Can this actually translate into things that are important for our patients? Yes. This can associate with saliva, with hospitalizations in outpatients. And you can see the microbiota dysbiosis ratio in the saliva and stool were really predictive of who gets hospitalized in the next 90 days versus who doesn't. What about the microbiota in inpatients? In the top left corner is a nice study from Taiwan in which they took acute patients admitted with hepatic encephalopathy and compared them to healthy people, compensated people, and decompensated people. And they found that there were specific microbial signatures of people who came back with hepatic encephalopathy versus those who didn't. On the right-hand side is our multi-center study in which we were able to find out that some bacteria, such as the Pseudomonas, etc., were very different in patients who actually who developed hepatic encephalopathy versus who died or versus who didn't. In the bottom, we are going to talk about it a little bit more, which is the admission serum metabolites to predict hepatic encephalopathy. But ultimately, microbial composition can predict significant things, including who can develop hepatic encephalopathy and recovery and recurrence. So now we've talked about the great role of the microbiota, the gut-brain axis, as well as this liver disease in hepatic encephalopathy pathophysiology. It's time to move on to the clinical classification and how to deal with this. So there are 4 axes for hepatic encephalopathy: the type, the grade, the time course, and the presence of precipitating factor. A is acute liver failure, B is bypass, which is rarely seen in humans. These are very few and far between congenital shunts. And C for cirrhosis. Of course, C is going to be the lion's share of patients you're going to see with hepatic encephalopathy. The more important thing is the grade, which is in green. Minimal and grade 1 have been actually pragmatically converted into covert. Why is that? Because no one knows what grade 1 actually is, because it was meant to be a West Haven criteria, were meant to be a semi-quantitative analysis of patients. They were not meant to be a clear-cut differentiation between one stage versus the other to a large extent. Where the semi-quantitative criteria become a lot more rigid and a lot more reproducible are overt stages, which is 2, 3, and 4. 2, when the patient is confused but is awake and maybe has asterixis. Number 3, stage 3, are when the patients are confused but are stuporous and lethargic, which means you have to wake them up. They're normally, they go fall asleep, but they are able to be awoken. Grade 4, as we know, is coma. So 2, 3, and 4 is what is now deemed overt hepatic encephalopathy. Grade 1 really is not. And this has actually been done by the European medical agencies and the FDA when you're designing trials for hepatic encephalopathy. The time course, which is in the blue, is very important for us to figure out where this patient came from and what the course is going to be. Because if the patient comes in with recurrent hepatic encephalopathy, which is further episodes within 6 months, and you actually look at the presence of the precipitating factor, which is the last factor on the right, if it is the same precipitating factor, we need to figure out what is it that keeps on causing this patient to get hepatic encephalopathy, because if you don't, like you say, history is bound to repeat itself if these things do not get better on their own. So you want to make sure that you actually look at all 4 of these axes for us to figure out whether this is something that we need our patients to interact with, we need to manage our patients better or not. So if you have a patient who's confused, who is grade 3, has cirrhosis, and has recurrent hepatic encephalopathy because of a precipitating factor, ideally this should be put in the chart. Grade 3, type C, recurrent precipitating factor, because in one fell swoop, you know exactly where this patient came from. What was the precipitating factor before? What is the precipitating factor right now? So that you can actually make sure that this precipitating factor, underlying precipitating factor, is fixed so that the patient does not come back with hepatic encephalopathy again and again. So hepatic encephalopathy, like hepatocellular cancer, requires a multidisciplinary approach, which is not really appreciated currently. And there are 3 villages. Typically, there's 1 village, but there are 3 villages of hepatic encephalopathy. The village within is the development of hepatic encephalopathy. I told you that it's not just the liver or the brain. There are many other organs involved. The village that is affected by HE is far beyond the patient. There's income loss, there's effect on the caregivers, there's personal well-being. There's, of course, effect on the society. If they're driving impaired and they have multiple traffic accidents, it just doesn't affect them. Of course, readmissions and death have a huge impact on the patients and the financial system, as well as the medical system. What about the village required to manage HE? This is where we come in. Gone are the days when there was one MD or one doctor specialist who would say, okay, let's manage this patient with hepatic encephalopathy and they'll have a good outcome. The answer is we need to actually diversify. Not only family and caregivers become our eyes and ears, physical therapy, social work, nutrition, mental health, including substance abuse, hospital medicine, including interventional radiology, and of course, outpatient MDs with advanced practice providers, RNs in the transplant team are really critical. So hepatic encephalopathy is a multidisciplinary, requires a multidisciplinary approach in every patient. Now, without realizing, we are already doing it, but we just do not actually put it all together. And I hope that changes at the end of this lecture. So there are three aspects of hepatic encephalopathy that we need to worry about: covert or minimal, inpatient management, and preventing recurrence. Let's go over these one by one. So we want to diagnose patients earlier in covert hepatic encephalopathy. If you remember, covert was a mixture of minimal and grade 1. For practical purposes, I'm using them as synonymously in this, but there are differences between the two, because grade 1 is definitely in patients that you know are definitely grade 1, they are a little more advanced than minimal. So why is this important? We can get a crystal ball into finding out who actually develops overt HE. It impairs patients' health-related quality of life. It is associated with driving impairment and accidents. It is associated with a poor overall survival. And because the patients and their caregivers are not able to work, it is a reduction in the socioeconomic status and definitely can be tested for. So what is the current prevalence of minimal or covert hepatic encephalopathy? In this large study done in 1868 patients with cirrhosis, the variability was very different, it was quite variable across 10 centers. And the standardized ammonia levels, a little bit more, we're going to talk about this, were very weakly correlated with the PHES, which is a 25-minute, 25-minute the cognitive test or paper pencil test that we do. And this is a meta-analysis that was also published in the Red Journal, which shows that the prevalence of minimal hepatic encephalopathy, and this is all where it has been tested around the world. And you can see some countries, it has been more than 50%. But typically, if you look at it, if it's done well, it's between 35 and 45% of your patients will have covert or minimal hepatic encephalopathy. So how do you test for it? Obviously, the gold standard is a formal neuropsychological test. It takes hours and it's very expensive and it's completely impractical. Neurophysiology and EEG can also be done, but again, this takes a long time. And in most cases, this requires another specialty. And anytime you have to involve someone else other than yourself, it takes a lot of time to do this. Then you have short batteries, such as PHES and the inhibitory control test, which take 15 to 30 minutes. PHES is the gold standard technically if you're going to do a research study, but in the US at least, it needs a neuropsychologist to order. A simple MD cannot order this, or a mental health practitioner, such as a psychiatrist, can order it. Neurophysiology, such as critical flicker frequency and response time, can be 10 to 15 minutes, and it can have some expensive equipment. But once you have that equipment, things can go very smoothly. And these are the tests that can actually be done much quicker. Encephalap, Quick Stroop, and ANT, or sickness impact profile questions that take 5 to 10 minutes maximum, or 1 to 4 minutes. Because what you want in minimal or covert hepatic encephalopathy, for a test to be simple, but not so simple that everyone passes. So you have to thread this needle and become a little more balanced so you can differentiate who has covert or minimal hepatic encephalopathy and who doesn't. And this is a real problem because the real world testing is less than 15% currently, and we may be doing a disservice to our patients by not testing them. So these are the real world tests that you can do. These are the 4 questions you can ask patients. I do not maintain balance. I act irritable or impatient with myself. I'm not doing any of my usual physical recreation or activities, and I'm eating much less than usual. If you can see 2 of these questions, if marked within if all 4 of these questions are marked by the patient over the last 24 hours as being relevant to them, then this patient has more than 80% chance of having covert encephalopathy if you did those longer exhaustive batteries. Then you have the animal naming test that takes like literally 1 minute. It has been inspired by the dementia literature. So if you ask the patients to write on 15 different animals, and if they actually have 15 or higher, if you ask them to write the number of different animals within 1 minute and their score is more than 15, is highly unlikely that, at least in the cohorts that have been tested, that these patients will have minimal hepatic encephalopathy. And then you have the Encephalap Stroop test that has been translated into several languages. This takes around 5 to 10 minutes to do, and this is validated across, and it predicts outcomes as well. What has been currently been studied is slow speech done by Dr. Bloom, and this has been associated with AI evaluation of this, and this can take around as little as 1 minute as well. And this is the quick Stroop, in which less than 1 minute you can be actually figure out who develops hepatic encephalopathy or not. Okay. What about ammonia levels? If there's anything that has divided the encephalopathy group that studies it, it is ammonia levels. There have been very nice studies done recently, both in inpatients and outpatients, that they could have prognostic capability. However, it is very, very variable. So always the devil is in the details. If you look at meals, if you're fasting, the ammonia level is low. If you're not, it's high. If you have an ammonia load, it goes down or goes up. If you have systemic inflammation, it doesn't change. But if you give a patient fluid, it goes down because dehydration increases ammonia levels. On the bottom left side is when 8 different centers across the United States were asked to send their ammonia levels of healthy people to a centralized lab. And we found that there were such huge variations with every lab, regardless of the upper limit of normal, that this made this individual ammonia level cutoff almost impossible. It can be exclusionary or patients who are confused if normal. So if a patient comes to you with cirrhosis and they are confused, and you draw an ammonia level and it is normal, that this patient is highly unlikely to have overt hepatic encephalopathy. But the reverse is not true. If a patient with cirrhosis comes into your office and they're okay, they're doing fine, but you draw an ammonia level, or an ammonia level was drawn by someone else, I'm sure you don't draw random ammonia levels, they were high, that does not rule in hepatic encephalopathy. So this thing is very important for us to realize. And these changes, so like any other lab test that you do, like fasting blood sugar, etc., if you draw an ammonia level, please make sure that all these other things are taken care of, including you cannot have a tourniquet, and the ammonia level has to be tested within 30 minutes into the lab and has to be drawn on ice. Of course, if you have an ammonia checker, that becomes a little less of a challenge. But again, that has to be validated across multiple sites. What is really important and has come because our patients are now living longer and are older is the impression what all can affect things in patients with cirrhosis and their brain function. So you can have the etiology and addiction that actually caused the cirrhosis in the first place: alcohol, opioids, obesity. You, of course, have cirrhosis related, which we are very comfortable with, which is hepatic encephalopathy, medications, and other complications. But something that we actually don't think about a lot is comorbid conditions, aging, including dementia or mild cognitive impairment, physical health, mental health, and social determinants of health, all of which can actually have a big impact on how the patient feels and how they react. As we already talked about, this impairs the daily function, impairs survival, and increases burden on the family. So are all cognitive complaints in patients with cirrhosis hepatic encephalopathy? And the short answer is actually no, because you have currently in the United States, what happens if you have a traditional practice, you actually exclude alternatives to HE, but like very, very crudely. And you usually initiate lactulose therapy. What you really should be doing, if possible, is doing specialized hepatic encephalopathy testing, which is not just cognitive testing for those 1 minute, 2 minute tests. You also have to go a detailed medication review, specialized evaluation and interpretation. Therefore, you can have some people who end up being covert or minimal HE, so therefore now need the lactulose. And if they were on lactulose and they still have this problem and you don't find an alternative, then you can start rifaximin. However, the testing is normal. That does not mean that the patient is okay. That means that the patient's cognitive complaints come from something else. So you want to actually specialize referral, give them a specialized referral. And if you actually find other diagnoses, because if you give them a questionnaire such as a stop bang questionnaire that actually rules in obstructive sleep apnea, this can actually lead you to actually refer them to whichever group comes in, whichever specialty can handle that. So altered sleep-wake cycle, we are going to talk about a little bit later. But what we found in our paper that was just published, less than 50% of patients with cognitive complaints being in the specialized clinic actually had covert HE. What they actually did have is dementia or minimal mild cognitive impairment. They had obstructive sleep apnea or some things that were alcohol related, which required multivitamins, etc. So what about sleep as an indication of HE? And if you remember grade 1, this is a big deal. If someone has alteration in sleep-wake cycle or not sleeping well, the assumption is that they have hepatic encephalopathy. Many things can affect sleep quality. The sleep disorders, of course, such as obstructive sleep apnea, we talked about, lifestyle, brain, chronic illnesses, aging, delayed sleep phase, and stress and anxiety. And on the right-hand side, you can see that the melatonin levels in patients with cirrhosis are completely out of whack compared to healthy controls. And therefore, patients have a very hard time going to sleep and remaining asleep, which causes them to have a fragmented sleep and high nighttime activity. So sleep alterations alone are inadequate to diagnose HE, and HE treatment does not resolve sleep problems. So do consider obstructive sleep apnea, alcohol-related or medication-related issues in these patients before assuming that all sleep problems in hepatic encephalopathy are, all sleep problems in cirrhosis are HE. So let's focus now. We talked about how to diagnose covert or minimal hepatic encephalopathy, and always important for us to keep an open mind. We had focused a lot on the gut-brain axis before, but let's go over what is important for the gut-brain axis and how this can actually mold our current understanding of treatments of hepatic encephalopathy or patients with cirrhosis gut-brain axis as a whole. So clearly you want to add something that is beneficial. What can that be? You can add fermented foods right here. You can have like yogurt or fermented milk products, whole grains right here. You have, this is rifaximin and lactulose, and this is FMT, which we're going to briefly talk about. Rifaximin and lactulose clearly are the mainstay for treatment for hepatic encephalopathy. You can remove something that is harmful, excess antibiotics, PPIs, as well as clean whatever's happening in the mouth. We're going to talk about, we've talked a lot about streptococcus and urease and other things in these patients. Okay, I don't know what's happening. You can indirectly fix the cirrhosis. If you actually fix the cirrhosis etiology by making sure the patient does drink, making sure the patient actually has gotten rid of hepatitis C, it's quite likely that the brain function will also get better. You can also use the microbiota to fix the etiology. In some studies, alcohol craving has been reduced with FMT. In some studies, chronic persistent hepatitis B has been reduced by FMT itself. And of course, that very rare patient that produces their own alcohol, the FMT can also reduce that, which would be prevents the progression to MASLD. So this is an overview of how the gut-brain axis can be manipulated to actually benefit our patients, with hepatic encephalopathy improvement being one of the many consequences of this. So let's talk about inpatient therapy. Clearly, you want to do 4 of these things at the same time. Initiate general care to make sure the patient does not develop aspiration pneumonia. You want to evaluate for alternatives, identify precipitating factors, and commence empirical therapy. And empirical therapy, if the patient is grade 3 or higher, clearly they need an enema, nothing by mouth, because they actually can then develop aspiration, which is really, there are no winners with that. So how can you predict who will develop advanced hepatic encephalopathy? In patients with cirrhosis who come in with who are not confused at this time, and you actually draw their blood at baseline, and you follow them to who develops coma. Now, the question you'll say, who cares who develops coma or not, especially if they're not comatose or they have grade 1 already to start with, grade 1 or 2? The reason is that twofold. They can't make their own decisions. So you need to know sooner rather than later whether they are good, where they are, what their wishes are. And the second and most important thing is these patients are often not treated as very good transplant candidates, because by and large, most patients with hepatic encephalopathy do get better, but those who actually don't get better, transplant surgeons typically are not very enthusiastic in transplanting them. So what we found in this, not only were microbial metabolites important, but thyroxine independently predicted who develops grade 3 and 4 hepatic encephalopathy. This was then validated, sorry, I forgot to put that reference, by Kulkarni et al. At GastroHep Advances from Hyderabad in AIG. So low admission thyroxine predicts advanced hepatic encephalopathy. So we need to do some more analysis to find out if this can be a way we can actually define who actually develops hepatic encephalopathy or not. This is how the treatments are focused on ammonia, but ammonia measurement really should not really be the cornerstone at this stage. You have the brain, the liver, the gut, as well as the systemic circulation. Unfortunately, the ammonia scavengers right now are not being developed to a great extent. Muscle, branch-chain amino acids, and the liver is L-ornithine, L-aspartate. in which the advantages from the intravenous are much, much higher than the oral route at this stage. So these are the drugs for acute hepatic encephalopathy episodes that are oral, which are non-absorbable disaccharides, which is lactulose. We're going to talk about this a little bit later. It can definitely cause aspiration pneumonia, dehydration. If you give too much lactulose, the patient can develop hypernatremia, and with too many bowel movements, there will be severe perineal skin irritation. Rifaximin is an antibiotic, but also works in other ways. If there are no potential AEs, but the problem is the cost. Zinc is usually not efficacious alone, but it's okay if you start it. PEG is much better than lactulose in certain head-to-head studies because it does not cause ileus, but it needs more study. But if you have it available, you can certainly do that. So once the patient gets better, sorry, I did not talk too much about L-ornithine and L-aspartate because it's not available in the United States, but there are very good studies done both from India and Germany in which intravenous formulations of L-ornithine and L-aspartate can actually reduce the HE outcomes even with and without rifaximin. So now the patient is ready to get discharged. How can we prevent this encephalopathy from recurring? If you remember, hepatic encephalopathy was the #1 cause of preventable readmissions in patients with cirrhosis. So you can use medication-related approaches and other approaches. So this is a checklist that is very important. And you look at this checklist, and it seems very obvious, right? Does the patient know that they have actually had overt HE? Does the patient know signs of recurrence? Do they have a scheduled follow-up? Do they have medications in hand and not just a prescription? Have potential recurrent and precipitating factors be investigated, and are they candidates for transplant? This is important because this is common sense, but it's always, almost always never done in our patients because we're in so much of a hurry to get them outside the hospital. This will actually bring them back to the hospital, and there's almost nothing to do with underlying medical treatment. So what can we do with lactulose? Lactulose is undergoing quite a renaissance, at least in the United States. It can reverse MHE, reduce mortality, prevent OHE, increase rate of recovery, and improve quality of life, but only if given well. In this unblinded outpatient study done by Dr. Tapper et al., there was a reduction, improvement in quality of life, change in animal naming test, and good sleep quality within lactulose compared to standard of care. But of course, this was not a blinded study. People on lactulose knew they were on lactulose, and the N was relatively small compared to the prior studies done from India by Prasad et al., in which the quality of life was improved as well. And this study done by Sharma et al. From Delhi also showed that the placebo and lactulose were very different. Lactulose prevented overt hepatic encephalopathy recurrence. But lactulose can cause a lot of bowel movements. And when we actually compared the Indian patients to patients from US, the Indian patients were much more likely to take the lactulose and much more likely to respond to them as well. But the patients from the United States were not very responsive, at least to the standard doses of lactulose, not the smaller doses. And lactulose non-adherence is the #1 cause for HE-related readmissions. So lactulose is a very cheap drug, but its human resource consequences are very expensive, and you really need to make sure that you counsel not only the patients, but their family members on how to do this. Can we actually reduce the amount of lactulose that is being taken? And in this study done by our group, in which we actually studied the quality, not just the quantity of stools, which means don't tell people to have 2 to 3 soft bowel movements, but ask them what their Bristol stool scale was. And what we found in 2 outpatient cirrhosis cohorts, before and after we incorporated the Bristol stool scale, there was a reduction in this total admission after the Bristol stool scale was put together. There was a lower HE-related readmissions, and there was greater stability of medication regimens. So Bristol stool scale improves stability of HE therapy and prevents recurrence. If the Bristol stool scale is above 5, for those who are not familiar, 1 is the patient has rabbit pellets, 7 is water. You want 3 to 5 for these patients. It's more than 5, don't increase lactulose or initiate it in these patients. They're not going to take it. They're going to stop it. These are the patients you want to start rifaximin sooner rather than later. But here you are, you're struck with a dilemma. You have a patient who's potentially might be confused, and you're asking them to estimate not only the number of bowel movements, but what the bowel movements look like. So is there an app for that? The answer is yes. There is this app called the Dieta app, in which the patients take the pictures of their poop, and it goes automatically to an AI-based calculator that calculates the Bristol stool scale and tells them to the patient and patients with and without cirrhosis. What we found is in this study that was done in multiple outpatients, and a corollary study was done in the Mayo Clinic. We wanted to study what was the comfort with the app and taking stool pictures, because it's not a trivial thing to ask someone to actually turn around and take their poop pictures and send them to a random, place. We wanted to also see if the lactulose dose adjustment when AI-generated BSS was communicated to the patients or not. So there were two phases of this study in which the Bristol stool scale generated by the AI was actually communicated to the patient and then was stopped. And then we wanted to see how the patients rated their BSS compared to the AI-generated one. So what we found is most subjects were comfortable with the app and taking their poop pictures. AI and self-generated BSS correlations increased over time as the patients got more and more. So it also was a learning effect of this. What is really interesting is we did not tell people, but they titrated their lactulose down already. They self-titrated the lactulose when the AI communication was switched on. So this may be a way to actually approach these patients. Although this app was developed for irritable bowel syndrome, now there's evidence from two centers, our VCU as well as Mayo Clinic, that this might be of use in patients with hepatic encephalopathy. So if lactulose doesn't work, clearly rifaximin is actually what we need to put in these patients. 550 milligrams BID, this trial has stood the test of time. If it reduces the recurrence, not only the recurrence, but the hospitalization. Rifaximin improves the gut-liver-brain axis. It improves driving simulation, changes microbial function, and actually could even prevent infections in these patients. However, it needs bile to solubilize for optimal bioavailability. So as you know, in patients with cirrhosis, as disease progresses, their bile secretions become lower and lower and lower, which is part of the reason why their microbes go rogue. So if there is a hydrophobic product that requires bile for its full solubility and bioavailability, which is the lowest in the group, which is advanced cirrhosis where this rifaximin is needed, then it becomes a problem. It is expensive in certain countries, certainly in the United States, which can be a barrier. It is obviously also not available in some countries, which is also a major barrier. What else can we do? We can actually work the patient's body and mind. You can actually prescribe them multiple exercises. There could also be improvement with mindfulness and group therapy in these patients as well, while you do all these medical things. You also want to make sure that things that can potentially increase or reduce their HE risk, like PPIs, opioids, beta blockers, and other neuroactive drugs, you can cut them down, remove them, or cut it down to the maximum effect possible in these patients. If a patient has persistent HE, please look for shunts, and those can be embolized. And if those embolizations can be quite successful in these patients. What is really a very important frame shift is actually enforcing checklists to prevent readmissions. Like the app that we saw with Dieta, there are apps like their Patient Buddy and SeroCare that have been studied to actually have daily patient data and figure out whether these patients can have reduction in hepatic encephalopathy and other admissions. What we found in the middle study with Ganapathy et al. In 2017 is 8 patients out of 20 the 20 that were enrolled, their HE admissions were prevented with this app that literally paid for the entire app itself, because admissions in the United States are so expensive. Again, in addition to optimizing medication, remember the third village: interventional radiology, nutrition, physical and occupational therapy, mental health, oral health, and system changes are important. These are the 3 villages again. Now talking about some specific special situations. Liver transplant. Do the things get better once the diseased liver is replaced by a healthy new liver? And the answer is complicated because, as you know, liver transplantation is not a perfect model. You have to have obviously immunosuppression and all these anti-microbial therapies that can itself cause brain dysfunction. So you have a patient who comes in with all these problems before transplant. During transplant, there are fluid shifts, ischemia, change in BP, and correction of electrolytes. Early, there's infections and immunosuppressive drugs, and late, there's early complications plus recurrence of disease and obesity. There's a substantial burden of neurological complications, which is 15% early, which is 5 to 10% infections, stroke, seizures, PRES, etc. And as time progresses, they can have other reasons for neurocognitive impairment, and 30% of these people have neurological complications afterwards. So what happens to their cognitive function 6 months after the transplant, which is kind of the sweet spot, where all the peri-transplant problem has resolved, and it is too early for the disease to actually come back. So you have cognitive impairment, it gets resolved, as you can see in the two graphs. The venous ammonia is also reduced, and the microbial diversity and function gets better as well. And the cognitive function is linked to the change in gram-negative bacteria such as E. coli and Klebsiella in these patients. So hepatic encephalopathy post-transplant by and large does get better, but patients who have cognitive impairment pre-transplant have a lesser degree of improvement after that. But the patients are also predisposed to post-transplant de novo events that can actually increase or worsen pre-existing cognitive impairment. What about transjugular intrahepatic portosystemic shunting, or TIPS? Overall, all comers have 20 to 45% risk of HE. It's cause of 50% of readmissions, can result in multiple episodes, major reason for poor health-related quality of life post-TIPS. This is only for elective TIPS. If someone has variceal bleeding, the risk of HE obviously should not prevent you from putting one in, because obviously the patient has to be alive for them to have hepatic encephalopathy. And the nice study done by Dr. Rudler et al. From in gut showed that this, even preemptive TIPS, it did not matter if someone had prior HE. The risk of HE post in these patients was similar, and it was relatively safe given the risk-benefit ratio. So what is the risk in this? Is again in elective TIPS. The risk of HE is higher in older patients without social support, patients with prior overt HE and current cognitive impairment, sarcopenia, advanced liver disease, and if you have alternatives to the TIPS to the patient. The benefit is very high, of course, if it's an urgent TIPS that we talked about, if it's a younger functional patient who's adherent and has adequate social support. Rifaximin, this nice study done across across France, in 14 days before and 168 days after TIPS, they randomized patients to rifaximin and placebo, and they found that the overt HE risk dramatically reduced in those who were given rifaximin. However, their overall rate of HE was very high post-TIPS, partly because those who were on lax dose before TIPS, their lax dose was actually stopped before they were given rifaximin. So this is a little overestimation of the risk of HE development after TIPS placement. Another thing that is very important is the fitness to drive, because obviously this requires multiple inputs, processing, and action. And if a patient has covert, minimal, or even prior overt encephalopathy, this can result into major changes in driving because of these synthesis and psychomotor speed changes. But it's important to know that it's not just MHE or prior OHE. Age, alcohol, fatigue, medications, driving experience, etc., all actually inform how good a driver it is. There is, and of course, weather in environmental situations. Consequences could be this could be accidents, near misses, or getting lost. However, if you stop everyone from driving, this can result in isolation, lower self-sufficiency, and damage to your relationship with the patient. So what should you do with these patients? You should be doing a non-judgmental driving history at every visit. On-road driving tests, simulation, driving history, cognitive tests are important, but you be familiar with what your local laws are. What we actually do is patients who have had an overt hepatic encephalopathy episode, clinical, in the last 3 months, we advise them not to drive, because this is the group that will have a recurrence of HE at the drop of a hat. There is no evidence to support a driving ban of all CHE and MHE without prior overt HE. You have to initiate and optimize HE therapy, and all those medications that I was talking about, like opioids, benzodiazepines, etc., you have to avoid, withdraw, or decrease them. Make sure that other comorbid conditions, including substance abuse, are taken into account, and refer to authorities for formal testing if needed. So what is being tested now for HE diagnosis and treatment? We already know about lactulose, rifaximin, inpatient therapies, LOLA, etc. But there are other therapies coming down the pike. You have rifaximin SSD, rifamycin SVMMX, FMT, golexanolone, and albumin. But more importantly, right now, remember all those things that we talked about. We actually were able to find out a microbial dysfunction, a microbial signature for both addiction, aging, post-traumatic stress, and dementia in these patients with the background of cirrhosis. So if the microbiota are being now aggressively studied across multiple centers in the United States to find out if this can actually do this. Rifaximin SSD is a formulation of rifaximin. If you remember, the current rifaximin is quite hydrophobic and requires bile. This is water soluble. For outpatients with controlled ascites, what the study found is 40 mg intermediate release was the best candidate to reduce all-cause mortality and hospitalization in these patients, but only on a post-hoc analysis. In inpatients using the same formula, same doses, SSD, IR, BID, 40 BID, and QD were the ones that reduced the time to the patient to wake up in this situation. So right now, the 40 mg intermediate release is an international study, which I think has centers in India also, called Red Sea, is being done to prevent all-cause hospitalizations and HE in patients with prior HE, ascites. What about FMT? This has been done in 2 small studies by our group with the enemas as well as capsules on the right-hand side. And these are further studies being done. We've just finished on a relatively larger study and hopefully we'll present the results soon. It did not matter what donors in this prior study, and FMT divided by oral or rectal route has been studied in these patients as well, with favorable improvement in these patients. So how does FMT compare to Clostridioides difficile in HE? Fresh stool, FMT from stool bank, frozen capsules, purified consortia have been studied in C. difficile. Individual bacteria, modified bacteria, and phages have not been studied to my knowledge. What about hepatic encephalopathy? There have been studies with fresh stool, FMT from a stool bank, and frozen capsules. There is one study done with an E. coli nissle that was modified that really did not have any impact on patients with cirrhosis and hepatic encephalopathy. Nothing else has been done. This is a study that is going to go into press, which is also a plenary presentation at the recently concluded liver meeting. This is rifamycin, not rifaximin, rifamycin SVMMX, which is a formulation, which is an analog of rifampin that opens only in the colon. So this is very different from the current rifaximin formulation that starts opening in the small bowel. We actually took patients with cirrhosis and minimal HE and divided them into half of them got placebo, half of them got rifamycin, and we studied the impact on gut muscle and gut brain. Not only was the microbiome function and composition changed, there was higher short chain fatty acids with favorable bile acid profile in rifamycin. Ammonia also reduced, but unfortunately, there was no change in cognitive testing. But to our surprise, there was a strong signal, higher hand grip, higher lean mass, and improved patient-reported physical function in those randomized to rifamycin SVMMX compared to those randomized to placebo, especially compared to their baseline. So this is a very important thing that needs to be studied further. These are all still, the ones we discussed are things related to the gut. But what is really interesting is goloxanolone is a neurosteroid antagonist. So this actually normalizes the GABAergic tone. We've been talking a lot about ammonia, but this is about GABA. So this improves cognitive function. And this is something that is really important for us to study further in these patients. And more importantly, it also improved sleep in these patients. What about hepatic encephalopathy and albumin? Many studies have been done with hepatic encephalopathy and albumin. Covert or minimal, our study with the HEAL study that was just published last year. In patients which are in the blue, Simon Tellero et al., Sharma et al. Have done these studies that were focused on HE. China et al. Did this landmark ATTAIR trial, but HE was not the focus of inclusion. And recurrence, Ventura cohorts in the beta trial did this, and Karaseni et al. In the ANSWER trial also did this. Again, Karaseni et al., HE was not the primary focus of inclusion or the study. This study in which we actually took patients on laxose and rifaximin, we did cognitive performance, quality of life after half of the patients got albumin and half of the patients got placebo, and this was blinded. We took a foil and made sure the patients did not know. In the albumin group, there was an improvement in cognitive function, psychosocial quality of life, and endothelial dysfunction. And importantly, this effect persisted even after albumin discontinuation in these patients. It's not really prime time to start patients with hepatic encephalopathy and albumin, because as the ATTAIR trial pointed out, random and indiscriminate use can actually make things worse for the patient. So right now, albumin uses are still related to SBP, acute kidney injury, etc., and after large volume paracentesis. So bringing you back to the 3 villages of hepatic encephalopathy, the village within, multiple organs have to conspire and fail to make this syndrome happen. The village affected is not just the patient, but everyone else around them. And the village required to manage HE is, again, not just the MDs, but many, many other facilities and many other specialties. So hepatic encephalopathy is a complex syndrome which requires several specialties in management. Overt HE staging around 4 axes during inpatient setting to improve treatment and prevention and readmissions are important. Appropriate use of therapies to prevent recurrence, improving nutrition, optimizing medications, and ensuring contacts with caregivers are needed. We need to have checklists on discharge. Microbial alterations and prognostications and FMT are potential emerging fields of management, and quality versus quantity of stools may be important. These are my collaborators, and thank you so much for your time.